good morning, depending on which part of the world you're in. And welcome to the RESECT webinar. It's the first in the series. And my name is Viru Kasibisvanathan. I'm the Chief Investigator of RESECT. This webinar is designed for you guys who are taking part in the study or who are thinking of taking part in the study to understand what you need to do to take part. We've also fitted in a lot of time for discussion and have some slides to help you make things as easy as possible. So this is a 1-hour webinar. The initial part of the webinar will mean that we can't see you, but you can see us and the panelists who I will introduce during my initial section. We do take questions, and those can be prompted and asked using the question and answer tab on the Zoom screen. And those questions will be monitored, and we may have live answering of those questions towards the end. In addition, after the 1-hour webinar, we will have a 30-minute social meet. And if you have been one of the 30 people who have been selected, your screens will be activated and we can see everyone. And for those of you who haven't made it into that 30, you can still stay and watch, but you won't be able to show your screen. So without further ado, let's begin. And I will put my slides on now. So the study we're talking about is RESECT. It's about improving quality in TURBT surgery. We'd like to thank all of our funders and sponsors without whom this study wouldn't have been possible. So I like to think of TURBT as the forgotten procedure. It's often something that is left to residents. It's a minimally invasive endoscopic procedure. And sometimes this can affect the outcome of our patients. And I think we need to change the way we're thinking about TURBT surgery. We know that bladder cancer is a deadly and expensive disease. There are 500,000 new cases per year globally. Most of those are non-muscle invasive bladder cancer. And the cost of disease, particularly monitoring and treating patients as they have recurrences and progression, is very expensive. This does impact the quality of life of patients as well. And those who have recurrences and progression have worse quality of life. We know from some of the early trials that recurrence rates have quite a variable incidence, which tells us there's something going on as to why this might be the case. We know that the quality of your TURBT surgery makes a big difference in some of these outcomes. And we know from work from Dr. Mariappan that when you assess your outcomes over a time period and show the people as part of that network how they're doing, it's actually possible to improve the quality of your surgery. So the main objective of the RESECT study is to determine if audit and feedback can improve the quality of TURBT surgery and thus reduce cancer recurrence rate. I'm very pleased and grateful for all of the collaborators around the world who have joined in this study. And we currently have 808 collaborators from 47 countries, which is a testament to the importance of the question we're asking and the effort that all of you are making. So just to reiterate what we're looking at, patients who have a TURBT, we're collecting data on their patient themselves, hospital factors, surgeon factors, and technical factors. And we're looking at the achievement of TURBT quality indicators and early recurrence rate. And we haven't revealed what the TURBT quality indicators are yet, as we don't want to influence your practice yet. So the moment that everyone's been waiting for is when we start data collection. The database will open on the 19th of April, which is soon. So I'm sure this has relieved some of the tension that many of you have been feeling. I'd like to thank the massive team who have been behind the RESECT study, without whom this study definitely wouldn't have been possible. And you can see by the nature of the people involved, this is hopefully going to be an important study that can improve patient care. So at this point, I would like to introduce our panel. And when I go to the panel, I would like to say where you're from, so the center and country, and what your role in the RESECT study is. And hopefully Vincent can now go to gallery view so everyone can see the panelists. So if I could introduce Kevin first. Kevin.
Hey everybody, I'm Kevin Gallagher. I'm RESECT study co-lead. I'm based in Edinburgh in Scotland, a specialist registrar in urological surgery.
Thank you, Kevin. And if I could introduce Dr. Nikita Bhatt.
Thanks, Miro. Hi, everyone. I'm Nikita Bhatt. I'm a trainee in the East of England in Norwich in the UK, and I'm RESECT co-lead with Kevin.
And Dr. Para Mariappan.
Hi, everyone. Nice to see everyone. So I'm a consultant surgeon in Edinburgh, and I'm on the trial steering committee.
And Dr. Eleanor Zimmerman.
Thank you. I'm Eleanor Zimmerman. I'm a urology registrar in the southwest of England, and I coordinate England and Wales for RESECT.
And Pat Hensley.
Hello, everyone. My name is Pat Hensley. I'm a urologic oncology fellow at the MD Anderson Cancer Center in Houston, Texas, and I am currently the US lead for the RESECT study.
And Dr. Juan Gomez Rivas.
Good evening. I'm Juan Gomez Rivas. I'm a urologist consultant in Madrid, and I'm the national coordinator for Spain for the RESECT study. Thank you.
And Dr. Kieran Clement.
Hi everyone, I'm Kieran Clement. I'm one of the urology specialist registrars in the west of Scotland. I am doing leading Scotland for RESECT, and I'm also on the steering committee.
And Dr. Meghana Kulkarni.
So hi, good evening. My name is Meg. I'm a trainee urologist in London, and I'm also part of the steering committee.
And Dr. Sinan Kaduri.
Hi, my name is Sinan Kaduri. I'm a urology trainee up in Aberdeen in Scotland, and I'm also on the steering committee.
And Dr. Gauthier Marc.
Hello, everyone. My name is Gauthier Marc. I'm a uro-oncology fellow at McGill University in Montreal. Will be back to my center next month in France, in Lille, and I will be the French national coordinator for RESECT.
And Dr. Jeremy Teo.
Hi, I'm Jeremy Teo from Hong Kong. I'm a urologist by training, and I'm the national coordinator for Asia.
And I know it must be pretty late in Hong Kong now, so thank you for joining us. And last but not least, I'd like to introduce Vincent Chan, who is our mastermind of tonight's webinar.
Thank you very much. I'm fourth year medical student at Leeds. Pleasure to take part in this. Thank you.
Okay, so at this point, I wanted to hand over to Dr. Nikita Bhatt to cover processes on registration, approvals, or authorship requirements as well. So Nikita, over to you.
Thanks, Vero. I'm just going to share my screen. Right, so yeah, as Vero said, I'm going to cover a little bit about approvals and authorship, site registration. So I'm sure a lot of you are familiar with this diagram that you might have seen on our website and on Twitter. It essentially outlays the process that this trial is going to go through. So essentially, to familiarize yourselves, there's a lead collaborator at every site who will manage the study at your site, who then registers themselves and the other collaborators at your site, registers the hospital through the hospital registration questionnaire, and it is their responsibility to upload the approval documents or to specify that you do not need approval where this is not required. and then to start registering anonymous surgeon records. Before all of this is to be done before we can start collecting patient data. So as we said, that our formal registration for your hospital sites is open up until the end of April. So if you've not done this, please go ahead and fill this out before then. So this is what we're looking at currently for formal registrations. Firstly, we're very impressed with the high level of completion of the hospital registration form. Almost 90% of you all have filled this out. 32 of you haven't. So please try and find the link to do the hospital registration. If you have an email on this, you can go back and try and get that, or you can get your lead collaborator to send you the link to finish this if you haven't yet. Coming on to the local approval form, over 100 of you have done this, but as you can see, a lot more of you need to do this, and this is really important because you cannot start collecting patient data until you've got this signed on the website. And I'll go through this in a little bit more detail in my further slides. And only 67 have additional collaborators registered, which is also quite important, and it's something I'll go through in the future slides. So as specified, the lead collaborator is our main communication point with your site. All the emails go through to them, and you'll get the REDCap login. And this will then allow you to start uploading your approvals and start entering your surgeon data as well as your hospital registration site data. So since a lot of you have already done this, I'm going to move through this quite quickly. This is your site registration form, and it involves about 13 pages, takes about 30 minutes to complete. You can download the PDF summary before you do this. Make sure you've got everything and go and fill this out at once if you haven't. And then more importantly, I'm going to come on to the local approval form. This is really, really important before you start collecting patient data. Now, some sites may not require local approval through the R&D department, in which case you still need to go onto the link that's been sent and specify that you don't need approval. If you do need approval, you need to fill out the form and upload it onto the RESECT database on REDCap. So this is what the link looks like. Your lead collaborator will be sent this link, and I'll share the email that they received. If you haven't done this, you can go back into your inbox and check for this email. It'll bring you to this link and through this form, which you need to fill. So if you don't need local approval, you need to specify no and sign here. So just really, really important to do this. And I just want to drive home that message today. So this just goes through, and this is all on our website. So if you're confused after this, you can go into the website, which answers this question about how to do this. So this is essentially the email. The subject was RESECT approvals, and there's a link here that you can click on to go through to the form that I just showed you. Again, if you can't find it at the very last resort, you can email us with the subject loss approvals link. But do check your spam and look for this email in your inbox before you do that. This is just a local approval form from my hospital, and just to demonstrate how it's filled out. Some advice on approvals. So RESECT is an audit, and it's not a human subjects research, and that's really important. That'll help you gain approval faster. Anonymous observational data is collected in the study after the patient has undergone their usual care, even in the prospective phase. So we're not altering their course of treatment. And you need to collect all eligible consecutive patients. So for example, in different countries like the UK, ethics is exempt because it counts as an audit, and the US has expedited IRB review with the waiver of consent, and we'll go through this in detail again. There is a data dictionary of a small unit of identification and a list of data types available on the protocol on the website. This is usually not required. However, if you do need a full data dictionary, it will be available in the next few weeks. And then I'm going to go through the authorship before we pause for a brief discussion. So again, this is where you start entering additional collaborators. And this is a requirement that will be assessed at the site level. So we will not be checking what individual people have done, except where there are disputes or where we may like to identify the top individual recruiters for the whole study. So really, it's their responsibility of the site to ensure that you've collected the minimum number of patients. And this minimum site requirement is 25 prospective and 25 retrospective TURBTs, of which 20 must be new tumor or first TURBTs. This minimum requirement can have 3 authors from your site, and this includes your supervisor. So 2 collaborators and a supervisor. You can add more authors. For every additional author, you need 10 prospective and 10 retrospective cases, of which 8 must be new. So, I mean, if there can be certain special requirements where we can consider your situation. For example, in the UK, trainees tend to rotate every year or every 6 months, in which case we can come to a solution on how you can manage this data collection between 2 sites or between your collaborators at every site if required. But again, as I specified in the beginning, this is at site level and will not check individual data collection. So then how do you register additional collaborators? Again, this is where the lead collaborator comes in. They'll be sent an email link where they can enter additional collaborators. And the subject in this email is the RESECT site registration and link to the collaborator sign up form. Once you press this link, you'll be brought to this sort of a red cap, a survey link where you can add, this is again from my local hospital, you can add the number of collaborators you've got in addition to yourself, and this is the lead collaborator, and then you have to go in and fill out the details of each of your collaborators. So this can get a bit confusing, which is why we've provided certain examples on our website for the minimum number of TURBTs you need. So you can go through these if required for 2, 3, 4, 5, etc., plus the supervisor. There's also a calculator that you can use to calculate the minimum number of cases required. It's also on our website. And this section goes through all of the authorship requirements in a lot of detail. So you can use that. So I'm going to pause here for a brief discussion. I'm going to hand over to Viru, and I'm going to stop sharing my screen.
Thank you, Nikita. And if Vincent, you can put it onto gallery view for all of the attendees as well. So if anyone's worried that there's a lot of information, relax, because we have everything on the website, and also this is recorded, so you can view it whenever you want. So I think it's a good point at which we can take some questions. So we have a question which I'm going to ask Kevin to answer. It's from Osama Waka of the Aga Khan University Hospital in Karachi, Pakistan. He says, we cannot submit the requested details for the RESECT registration process without the approval of the Ethical Review Committee, as these details involve questions on our hospital's current practice. Their ethics approval is expected to take up to 1 to 1.5 months. Will the RESECT registration still be live by that time, or can we pre-register without submitting the practice details? Kevin?
So great question. Thanks for submitting it. So I'd say we've said that the deadline for site registrations is going to be the 1st of May. However, that deadline doesn't mean that you have to have completed your site registration. You just have to have begun the hospital registration form. So if you insert your hospital name, your collaborator's name, and your name, you can hold off submitting the rest of the data until you have your ethical approval, and that's perfectly okay.
Brilliant.
And just to answer one that's come up in the Q&A, since it's very simple, yes, you can go back and edit it, the hospital registration questionnaire, via a link that you should have got after you completed it. And if you've got any problem with that, you can email us to ask for access back to your survey. We can get you back in.
Okay, thank you, Kevin. I'm now going to pose a question to the international panelists. And this question is about the approvals process you went through in your own country So first of all, a comment on whether it was easy, difficult, what you did. And secondly, if there's a new center from your country who wants to take part, what approval process do they need to go through? So I'm going to ask this question first to Dr. Pat Hensley.
Thank you, Vera. I think we'll find that in the US, things were generally more difficult than some of the other international sites, as chart audits in the US are almost universally considered IRB exempt, or excuse me, IRB expedited and not exempt, even when the data is completely anonymized. The problem that we've been facing with our initial interactions with IRBs is that they take exception to the prospective phase of the protocol, and specifically the use of the word prospective, and then they want to require patient consent and full IRB review. Another major issue in the US particularly is just the heterogeneity between the different IRBs at the different centers. Some centers have gained approval within days, and others are still working on their approval after months of revisions. It is imperative, as I think that others will allude to, that the IRB understand that this is a retrospective audit, and there has to be a waiver of informed consent. What we did specifically at our institution was we just simply amended an existing IRB protocol from our non-muscle invasive bladder cancer database. And we will essentially be performing our retrospective patient data collection in phase 1, and then identifying our prospective patients, and then waiting 3 to 6 months or so, some reasonable time frame before entering the data for the prospective patients. And this way, we don't necessarily have a prospective cohort in the true sense of identifying individual patients and entering their data as we treat them. For new sites, please follow the link on the website to register, and contact me. I do have some IRB templates and some other tools that have been useful in helping the US sites in particular kind of work through the IRB approval process. So reach out to me specifically with any questions or if you have any interest. Thanks.
Thank you, Pat. So I think that was absolutely key for the prospective phase, which is labeled prospective. Actually, you can collect that data after the patients have gone through their processes, which means it's the same, in fact, as a retrospective phase. It's just the time at which you collect data for the prospective phase is after a certain time. So I'm now going to ask the same question to Dr. Jeremy Teo.
I think for most Asian countries, IRB approval will be quite easy because of the nature of the study. And consent is usually waived as well. And so in most Asian countries, it will take about 2 months to 3 months to get everything ready. Since the documents are all ready from the RESECT website, it's actually quite easy to submit them and get approval. Of course, it may vary across the different centers and countries, but if you have any problems, feel free to reach out to us, and then we'll try our best to facilitate.
Thank you, Jeremy. And I'm going to ask the same question to Dr. Gauthier Marc from France.
Yeah, thank you. The process I've been through was quite tough for the past month, but now everything is approved. So the RESECT is officially approved for France. The only thing that centers need to do is directly reach out to me, where we will design a contract between my home-based hospital in Lille and your center in France. So it's actually now quite easy. The only thing that we will have to do in France, which is not the case for UK, for example, is to have patient consent. So every patient included in the prospective phase will have to consent to be included in the study. And for retrospective cases, we will have to send out consent to patient, and they will have a 2-week period to reply and refuse to be included in the study. If they do not reply, they will be therefore included. So don't hesitate to reach out to me. There is still time to integrate more centers. Don't hesitate.
Thank you, Gauthier. So it sounds like you've done the hard work in getting your central approval, and it's still hard work, but it's been made easier by your initial effort. So thank you for that. And I'm going to ask the same question finally to Dr. Juan Gomez Rivas in Spain.
Thank you, Vera. regarding Spain, I think there's a mix between what Dr. Hensley said and what the rest of the team said. Is first of all, although it's anonymized study and anonymized data, we need the RBT approval, and it's quite difficult because of our. I think it's because our Mediterranean style that everything is very bureaucratic. So at the first time was quite challenging to get the approval, but as Jeremy said, everything is on the website of RESECT, and we had to translate some of the documents in Spanish. We get the approval from one hospital, which is Hospital La Paz, is my former department. And after you get the approval from one hospital, the rest of the hospitals or the rest of the people that wants to join the study, what they only have to do is to ask for the approval for La Paz and to validate this approval in their departments. So for those that wants to join now the RESECT study, is quite easy because it's already approved in one department, and what they have to do is to ask me by email or if they have my contact phone, ask me for the approval for La Paz Hospital, and I will handle it to them, and it will be quite smooth and easier that was for us during 2020. And of course, we had also to deal with COVID-19 because the IRBT were also reviewing many COVID-19 studies, so it was quite delayed, the approval. But now we're set up to start.
Thank you, Juan. So just to let you know, in the Q&A, some of our team are answering those questions. We will also have an opportunity, hopefully at the end, if we have time, to address some of the questions we don't answer now. I'm going to have two more questions now on authorship requirement. And I'm going to direct the first one to Dr. Sinan Kaduri. Specifically, Sinan, at your site, with respect to the authorship requirement, how are you putting your collaborators together?
Thank you, Veru. So in our site, it was actually quite straightforward because at the pre-registration, we had an interested trainee and an interested consultant or supervisor. And then as the registration process started, there was another collaborator who was interested as well, another trainee. So actually we ended up having two collaborators who are trainees and a supervising consultant, which is allowed for as long as they collect 50 cases, so 25 retrospective and 25 prospective cases, then they should all make authorship. I suspect as the study rolls on, there may be trainees who might be more interested in joining. And as we've mentioned before, that's allowed, that's fine. But in order to be eligible for authorship, they need to have an extra 10 retrospective and an extra 10 prospective cases. And in our center, it's a moderate volume center, so that should be feasible. And we're also very attentive to the fact that 80% of those have to be new bladder tumors.
Thank you, Sinan. So I'm now going to direct a question to Kevin. And this is a question from Holly from Frimley Park Hospital. And it's a question on whether every surgeon who you've registered an ID for on REDCap also needs to be a collaborator.
Thanks, Veru. That's an important point, Holly, that I want to make very clear. That surgeons and collaborators are different things. Although they may overlap, some surgeons may also be collaborators. The surgeons doing the surgery are collected in an anonymous way. So every surgeon who does one of the operations, be it a trainee or a consultant, needs to have a record in the database. And the people who are doing the study, i.e. collecting the data, the collaborators, are completely different people. So that's an important distinction to be made.
Thanks, Kevin. So at this stage, we're going to move on to a short presentation on surgeon registration. And I'm going to ask Nikita to present her slides on that, please.
Thanks, Vero. So yeah, just really specifying what Kevin already said about surgeon registration. So this is number 6 in the flowchart, is where you register anonymous records for each TURBT surgeon. And this includes consultants and trainees. And anonymous because we don't know who the surgeon is when you enter their data. You will have a local key where you record the surgeon's initials. And we don't know who that surgeon is based on the number that we have got. And I'll go through that now. Just to go through this briefly, Sinan has put together a really good video on the website on how to register surgeons in your center. And you can see this on YouTube with timestamps. So this is what I was saying. So every surgeon will be given an ID. So this is everybody in your hospital who performs TURBT, whether they're consultants or trainees, and they need not be authors on the study. So these are different people, and you need to register them with their initials and a bit of their operative experience, which I'll go through now. And what we will see is a surgeon ID. But we won't know who the surgeon is, only you will. So you need to be really careful and make sure that you record each surgeon against their ID, because you're the key to this, and we won't have this information, which is why this is anonymous for us. So we've divided surgeon into 4 grades. So this is trainee, which is a classic sort of trainee or resident in urology in the UK and in other countries. A fully qualified urologist, which is a consultant or an attending. For some countries, there's a grade called a non-training or a non-consultant. Someone who is not a consultant or attending, but who is also not on a urology training program. Sometimes they're called trust grade or associate specialist in the UK. And then there's the junior doctor who is not in a urology specialist training program. And then to try and quantify their experience, we have added training years, and these are defined specifically for each of these. So if someone who has completed their training and is a consultant, so how many years of training did they undergo before becoming a consultant or an attending? For the non-training, non-consultant, how many years of urology operative experience did they have before taking up the current position at which they're operating at the moment? And then for trainees, it's straightforward. It's how many years have you had urology training for? And if you're halfway there, you add a 0.5 for the 6 months. And then how long has the surgeon been operating at your hospital? Are the few questions you need to register for each of your surgeons. We'll go through a bit of discussion again, but I hope this is clear that these are not authors, these are surgeons performing TURBTs. And that's all from me. These are all our sponsors, and a big thank you to them. You can email us on this email address, and you can also go through everything I just said on our website. Thank you.
Thanks, Nikita. We can make sure we go back to gallery mode for all the attendees to see all the panelists. So I've got a question for Dr. Maria Pennell. And in our surgeon registration survey, we ask people to estimate their experience. Here's a philosophical question. What are the challenges of measuring TURBT experience in a standardized way?
I'm actually so glad you've mentioned philosophical, Vero, because this was the very question I asked myself when we first started the quality of TURBT work all the way back in 2005. And actually, despite the work that we've done, it's not as simple as just describing it as years of experience or numbers of operations, because it has to be much more nuanced than that. And as you know, there's so many elements involved. So I'm really quite excited about the potential big data that's going to come out of RESECT. And perhaps one of the things we'd like to achieve with potentially the sort of secondary outcomes is actually the ability to measure experience from the data that comes out of RESECT. So quite excited about that element of things. But for the moment, unfortunately, we have to use metrics that we already know. So things like years of experience, grade of surgeon, etc., which are being collected as part of the surgeon survey.
Thank you, Param. So the next question I'm going to direct initially to Kevin, and then I might ask our international panelists to comment as well. So, Kevin, we've got a question from Simona Ipatiliti from King's Lynn. She says, if some surgeons do not wish to share their details, what shall I do?
Okay, thanks for your, I suppose, if a surgeon wants to remain completely anonymous, do you mean their identifiable details? Then that's fair enough. We want to emphasize that actually this is kept completely anonymous. We do have an initials, a box where you can insert the surgeon's initials if you wish, and that's purely for your own use so that you can remember what surgeon relates to what record. But actually that is not required, and if they really want to be anonymous, don't enter their initials, and just make sure that you keep a key linking the ID number to the surgeon name private at your own hospital, and then the surgeon's always anonymous. If we're talking about so that bit's simple, but let's think about what if a surgeon doesn't want their operation data audited in this study. And I'd hope that situation will be quite rare, and hopefully everybody will be willing to enter into this in the sort of you know, in the good-natured way that we intend it. And it's why we have anonymous feedback that's going to be done. We're not aiming to you know, name and shame anybody here, but also at the institutional level, I would expect that audit is sort of expected of most surgeons anyway. I don't know what other people think about that.
So it's probably a good time to get an international perspective on it. Jeremy, in Asia, perhaps you can comment in general or in Hong Kong specifically, if there are surgeons who didn't wish to share their details in the respect that Kevin commented on, how do you deal with this?
I think in most Asian centers, it shouldn't be a problem because, as Kevin has mentioned, it's anonymous, and also ethics approval can be obtained at an institutional level. So actually, in my experience, I never had this problem in those studies across different Asian centers. So I don't think it's a big issue in Asia.
Thank you. And I'm going to ask the same question to Gautier.
Yeah, thank you. That's a great point to raise, but I think it's not going to be much of a problem in France, specifically because it's fully anonymized. However, if one surgeon wants to really is pretty reluctant to provide data, I think each lead site collaborator can chat with him and just explain that his name is never going to be mentioned. It's just the name of the site, and I will be happy to help for the discussion, because I do think this is really important data that we should all implement. So I do expect that will be seldom the case in France, and please contact me if you need assistance for anything.
Okay, so at this point, I'm going to move on to another question, which I think Nikita covered reasonably well in her talk, but it might be worth emphasizing. So Kevin, this is a question for you. So we have Imo Ibiok from Milton Keynes, who said there was some difficulty in finding non-trainee registrars or specialty doctors or associate specialists into the surgeon registration form. And a second question, which I'd like you to take perhaps with that, is from Christos Gikas, a consultant in Bradford, who said, how do we ensure the same surgeon's registration ID on REDCap between different collaborators of the same site that use different REDCap accounts?
Thanks for your, yeah, I'll just answer that without sharing screen, I think. So the first question, you were struggling to fit a non-training, non-consultant doctor into the categories on the surgeon registration database. There is a category for non-training, non-consultant. I suppose maybe the difficulty arises if we're talking about somebody who's post-core training and not in a training program, so they're kind of a junior non-training, non-consultant versus somebody who is later in their training, like a locum consultant, who's also non-training but non-consultant, or has a staff grade post, they would both just go under that category as it is in the database currently, and then you would explain, we would see their difference in experience through the other questions. So how many years of experience do they have before they took up their current post? In the junior case, it's going to be very few, or 0 or 1, and in the more senior case, it'll be more. So we'll know it from that. But if you've still got difficulty with that, please email us resect@bursturology.com, and we'll give you a specific answer to the specific scenario that you have. Secondly, then, how are all of the different collaborators going to know which code is which surgeon, when it's probably going to be different people that makes the record for each surgeon? This is explained reasonably well in the video that Sinan has made, which is on the website under the study resources page. And also Nikita mentioned it. It's important that you keep a key at your site of what code relates to which surgeon, and you share that with all your collaborators. The way we do that at my site is simply to keep a spreadsheet in a shared drive that we all have access to. If you don't have that kind of thing, then a paper form in the office, which links the surgeons to their code. But in addition, as a safety net, of course, then we have the surgeon's initials, and then some details about them, which might be able to identify them to you. So when you come in to fill the patient record in, and you get the drop-down box asking you to select what surgeon did the operation, you'll have a little table on your screen which shows you the surgeons in the code, the initials that were entered for that code, the years of experience for that code, and the job name for that code. So you'll be able to tell, reasonably well from that information which surgeon is which. But the key is to have an Excel spreadsheet. Thanks.
Thanks, Kevin. So at this point, I'm going to ask Kevin to talk through his slides about patient data entry. You're muted, Kevin.
Thanks, Vibert. So we're now getting on to the bit that so many of you had questions about, and this is the patient data collection, the real meat of the study. So this is going to open on the 19th of April, all going well. We've been working very, very hard on developing a easy to use, excellent database with lots of useful features for you to enter data about your patients. So I'll cover, first of all, the inclusion and exclusion criteria. So it's very important to get this clear in your head. The inclusion criteria is that it's all consecutive patients undergoing transurethral surgical treatment of histologically confirmed urothelial carcinoma. So that means that you have to know the pathology before you can include a patient or not, which means at all times throughout the study, you will be adding collecting retrospective data, essentially. The prospective phase is just termed so because it occurs after you have joined and started taking part in the study, versus the retrospective phase, which has happened before. But all of the data is collected retrospectively because you must know that they have urothelial carcinoma. You can include all TURBT procedures of any type or technology, or biopsy tumor removals. So this is where biopsy forceps are used to completely remove a small tumor, and this is considered the primary treatment of that tumor. So, but we're not talking about diagnostic biopsies of diffuse lesions. You can include first ever tumors that patients have, as well as newly detected recurrences, but recurrent cases must be only 20% of your total. So the study is set up so that you should consider all TURBTs done for urothelial carcinoma as potentially eligible unless they meet any one of the exclusion criteria. And the exclusion criteria are the patient is excluded if the procedure is done purely for diagnostic, tumor reduction, or symptomatic purposes. So that would be things like a biopsy of a diffuse lesion or a biopsy of a lesion that clearly was not removed by the procedure, resectional biopsies or palliative resections for symptoms. These kinds of cases are excluded. If preoperative imaging confirms muscle invasive, locally advanced or metastatic disease, the patient is excluded. But please note, importantly, it doesn't matter if the histology from the procedure shows muscle invasive disease, as long as there was no awareness of this preoperatively. So if you did a procedure for a tumor that was, for all intents and purposes, before the operation, non-muscle invasive, you did your best to remove it, and the histology came back as T2, this patient should still be included. But if you knew before the operation, because of imaging, that it was muscle invasive, they should be excluded. I hope that's clear. If you knew that they had upper tract urothelial carcinoma preoperatively, they're excluded. Again, if this comes to light later on, it doesn't matter. They're not excluded. It's the preoperative knowledge of this. And emergency cases are excluded. So that we're absolutely clear about this in the database and that we get it right for every patient, I'm sure you might get a little bit fed up doing this, but for every patient, we're going to ask these questions, you to confirm these questions before you begin the data entry. And there's this eligibility checking section at the beginning for every patient. This example patient had what looked like more of a diagnostic procedure, a resectional biopsy, and it was also done as an emergency case. So they get the message that you cannot include that patient in the study. To include the patient in the study in these questions, you need a yes for urothelial carcinoma and a no for all the exclusion criteria. Then you get, excellent, your patient can be included. So that will happen at the start for every patient so that we're clear. Just like the surgeon ID key, identity key, you're going to need to keep a patient identity number versus study number key safe at your hospital. This should be stored securely and only accessible by the direct care team. The direct care team has access to this patient record as part of their usual job. Therefore, they can have access to this. We should never have access or be shared the identity of any of the patients. But it's important that you keep this key, and I've sort of give an example of how it should look, and we'll share a blank spreadsheet like this of how it would look as you were going through the study. And what you would do is get your list of patients that you've identified, and then begin working through them one by one, consecutive patients, and checking whether they're eligible. You could enter yes, checking whether they're a first or recurrent case, and then write your name as the person who's entering the data about that patient. And this is also really important because when a different collaborator, say Katie, comes along to enter data about a new patient, she needs to be able to check that that patient has not already got a record in the database. So she can look at the spreadsheet and see that the patient she's about to enter has not already been entered and begin creating a new record. So we've written a detailed study manual that includes this diagram to help you understand how the study will run. So on the left in the green, we have when the retrospective cases were done. Then the patient project will open on the 19th of April. You begin entering data about your retrospective cases. Important point to note is that the retrospective data entry will not close. That will be open throughout the study. You can continue collecting as many retrospective cases as you wish and entering follow-up data about them at any stage throughout the study. It won't close until the very end of the study. Once you've submitted 25 retrospective cases, it's undergone some analysis, you will be invited to begin collecting prospective cases. The prospective cases will come after that date that you're invited to begin collecting prospective or phase 2 cases. So how would I actually manage this or do this at my hospital? So I'd have a team meeting with all my collaborators. I'd use the calculator that's on our website to figure out how many cases it is we're going to need to collect. Then I'd identify the cases, all of the cases at my hospital. So what I'd do is ask the theatre data team, if you have one, or some other way of identifying operations done at your hospital, to provide a list of all TURBTs and biopsy diathermies done between two dates. If you need to know the OPSC4 codes for TURBTs, M42.1, and for biopsy and diathermies, M42.2. I'd get that list, I'd put it in a spreadsheet, and then I would make that spreadsheet available to all my collaborators. And I'd ask them to go through them one by one, entering just as I showed you before, and marking when they find an eligible patient and enter them into the database. Noting that you want to include 80% as first tumor TURBTs, so you would work through them probably first. Enter the data, keeping a record of the study number. Once the retrospective phase was completed, wait for the invite to start the prospective phase. But in that time, I would keep working on the retrospective cases, because we have five collaborators at my hospital, so we're going to need to enter more data than just 25. But once you've done 25, you can then begin the prospective phase. I wanted to make a little note about Quickcon levels. So maybe running on a little bit. Quickcon levels, very quickly, each patient will have to have designated the Quickcon level at the time when they had their operation. And that's a level which tells us how bad the pandemic was in your hospital at the time. What I suggest you do is write out the dates between which each Quickcon applied, and share this with all your collaborators so that they can know very quickly what the Quickcon was when that operation was done. So people have been asking about the timelines for the study, and I summarize it here. I want to say there's plenty of time to do the study, and people are worried that they're going to be too late. Not at all. You need to have begun the registration, so put your name and your hospital in by the 1st of May, but you don't need to have completed it by the 1st of May. Retrospective data collection will be open for the entire study, and it's likely that data collection will close in August 2022. We'll probably stop accepting new cases about 3 months before that, and the 3-month lag will allow the follow-ups to occur. So really, it's going to be open for 15 months from April all the way to sort of August 2022 for data entry. Just very briefly, you will in the next couple of weeks see in great detail exactly what the database is going to require you to collect, but there's data about the diagnosis, about the index operation, about a read TURBT if they had one, and then their first follow-up check. Simple as that. I think I won't go into this in too much detail, apart from to say, if you are changing hospital in August or October and you're worried about this, please don't be. There are lots of ways that you can complete the study adequately and get a lot out of it, even if you're moving hospital. So please just get in touch and we can give you advice on that. And I'll leave it there. Thank you very much.
Thanks, Kevin. If you could stop your screen share, and if Vincent, you could put it onto gallery view. So thanks for that. I think that was really clear, Kevin, and I'm sure everyone appreciated those answers. We have around 5 minutes left for key questions. So I'm going to ask 1 or 2 key questions. The first is to you, Kevin. No rest for the wicked. So we have a question from Dr. Hamid from Jakarta in Indonesia. And their question is, what type of intravesical installation is in the inclusion criteria for the study?
Thanks for asking that. It illustrates an important point that I wanted to get across, and you've seen from the inclusion criteria that there is no stipulation about what the patient must have had or what you must do in order to be included in the study. Remember, this study is an observational study of your practice, so it doesn't matter what you do normally, you can include the patient in the study so long as they meet the inclusion criteria and not the exclusion criteria. In fact, it doesn't matter if you never do intravesical installations. you can still definitely take part in the study.
Okay, great. And we've probably got time to go to one international panel member. So I might ask Dr. Hensley to give an example of how he would identify and screen cases in his hospital suitable for inclusion into RESECT.
Thank you. I think as Kevin alluded to, the absolute most important factor is about selecting cases is finding consecutive cases, because you want to avoid any bias related to cherry picking, certain cases that were easy or where the faculty member did the whole thing, or potentially you had more guideline concordant care. So it's important that these are all consecutive cases. So what I'll do, just as Kevin pointed out, I'll pull all the TURBTs in the facility over the retrospective and prospective phases. And I think this will probably be the most labor intensive part of the study, but kind of going through and hand selecting which cases meet inclusion criteria, but not specifically leaving anything out. They have to be consecutive cases. So that's how I'll do it.
Thank you. Consecutive is the key. So at this point, I might ask Eleanor if she has any important questions that she thinks could be answered in the last 2 minutes. So maybe 1 or 2.
Well, we've been bombarded with questions in the chat, but I think everyone has been working together and pulling together to answer them. So I'm hoping that we're actually on top of it. The one thing that I was about to just clarify for Shiv Pandyan was if prospective collection should have histopathologically, if I could pronounce it, that would help, proven malignancy, none of the new bladder tumors will form part of the prospect evaluation. And it is really just to clarify the term prospective here. So Kevin, would you mind just going over that one more time, please?
Thanks, Eleanor. I'm very happy to go over that again. So although we've termed it the prospective phase, you will still collect the data retrospectively. So what I propose that you do is with maybe a 3 or 4 week lag, you look back at the operations. So say in July, you look back at the operations done in June, and you check that they had urothelial carcinoma and include them in that way. I would plan to do it at our hospital on a monthly basis and review the cases done the previous month so that we know that they were urothelial and met the inclusion criteria.
The only exception I would suggest would be in the case of somewhere like France, where if you have to get patient consent for that phase, you could include consent for every potential eligible patient, which might be easier at that stage when they meet you in clinic. And then afterwards, when you know what the tumor is, you can either decide to include or not to include them. That might be the only minor exception. Okay, well, it's 8 o'clock GMT. So I would like to draw the main part of the webinar to a close. I would like to thank all of the speakers and panelists for attending from around the world. It's probably time for Jeremy to get some sleep. He's been up late. And I'm very grateful to all of the collaborators around the world who are working together to make this study a success so that we can improve the care that we give our patients. Any questions that haven't been answered, we will look at those and put up answers on the frequently asked questions. And at this point, we can stop the recording. We can stop the live stream. And I would like to say goodbye to the majority of attendees. However, we are now going to do a social session, which is not going to be recorded and not going to be live streamed. And the 30 people who have been emailed to say their screens can be shared will be invited to share their screen. The remaining people can still watch. You just won't be able to actively